My name is Kwong. I'm the Executive Director at the Center for Connected Health Policy, and I'm here today to talk to you about legislative and payment issues for telerehabilitation. A few disclaimers before we start today. Please know that any information that I provide in today's talk is not to be considered legal advice, strictly for informational purposes. CCHP always recommends that you consult with legal counsel if you're interested in a formal legal opinion. And also know that if I happen to mention a company or show some type of product, know that neither I nor CCHP has any type of relevant financial interest, arrangement, or relationship with such a company. A little bit of background about the Center for Connected Health Policy. We were established in 2009 as a program underneath the Public Health Institute as a California telehealth policy organization. We became the federally designated National Telehealth Policy Resource Center in 2012 through a grant from HRSA, and we've been serving in that capacity ever since. We also work with a variety of other funders and partners on the state and federal level. We also act as administrator for the National Consortium of Telehealth Resource Centers. What that is the other 14 telehealth resource centers who are in the same grant program as CCHP decided that we would try to work collaboratively together on joint projects. CCHP acts as administrator for those projects. We are also the convener for the California Telehealth Policy Coalition, which is a coalition of over 100 statewide organizations who are interested in advancing telehealth policy in California. Now, historically, telerehabilitation has not been covered by many payers, either public or private payers. It's been one of the areas, one of the specialties where there's been some hesitation in how effective the technology could be used to provide those services. Medicare and a lot of Medicaid programs before COVID-19 didn't necessarily have those providers who typically provide those services on their list of eligible providers who could utilize telehealth and also get their services reimbursed and covered. Also, a lot of policymakers question the quality of those services if telehealth was utilized to provide them. So it's been historically like very limited in what can be done for the rehabilitation field with technology and with telehealth. COVID-19 definitely changed everything in healthcare for a lot of different groups and definitely for rehabilitation. This is a very 100,000-foot level overview of the telehealth policy changes that happen both on the federal and state level. Obviously, there's like a lot more detail, but these are sort of the common areas in which telehealth policy was impacted. You'll see that there are very similar sort of issues that were addressed both on the state and federal level, and I'll get to that in a second as to why that exists. But they were areas around what was covered mainly, sort of what was reimbursed, what was allowed, what a payer would have to like pay for if telehealth was used to provide those services. There were other sort of policy areas that were touched upon that impact the utilization of technology in telehealth, such as prescribing or privacy and security issues and licensing. But a lot of what the changes we saw in response to COVID really related to what would be covered by a payer, whether commercial or public, and also what services would be covered. Let's touch upon federal policies first. And when you talk about telehealth and federal policies, a lot of that involves Medicare. That is the majority of where the established telehealth policy is on the federal level. It's in the Medicare program. There are other things that, again, do touch upon telehealth or are specific to telehealth, such as like prescribing and controlled substances, but really where a lot of the majority of federal policy is in Medicare as it relates to telehealth. And to understand the Medicare telehealth policy, you have to understand that Medicare actually looks at the use of technology providing services in two ways. They look at it through a telehealth lens, which is controlled mainly by federal law, what's in federal statute. So there are certain requirements, certain limitations on what you can use the telehealth technologies for. And then there's another lens that they look at. It's called communications technology-based services. Now, this other lens, the CTBS-based services, they utilize telehealth technologies to provide those services, but Medicare does not view them as telehealth services. So they're not held to the limitations that are in federal law. And the reasoning for this is when you're talking about telehealth, you're talking about a replacement for services that typically take place in person, whereas communications technology-based services are services which typically would not happen in person, but technology has allowed these services to actually be effectively provided now. Just the advancements in technology, the evolution of technology is something that we hadn't imagined that typically couldn't be done in person, and we can now do this, and we should be covering it. So, for example, if you're tracking a patient's hypertension, and you're getting readings through technology. They're taking readings at home and sending that electronically to their healthcare provider, and they're doing several readings a day for like a period of time, like over a week. You typically would not have them do that in person. Like a patient wouldn't come in several times a day to a physician's office and get those blood pressure readings. So something like that is why they have this other bucket that they call communications technology-based services and not telehealth. And I'm spending a little bit of time on this is because this is in Medicare CMS's eyes two separate distinct things, and they apply different policies to them. But over during COVID, the two sort of became very intertwined in some ways, and I think it caused some confusion for some providers. So for federal policy changes during COVID, as I said, a lot of it revolved around Medicare and a lot of it revolved around reimbursement. So reimbursement policies can be divided up into like four elements. So you have the service, the location, the modality, and the provider. So what type of service is covered? What type of location is the patient in during the time of the service? What modality is used to deliver the service? And what provider is providing that services? And these are where you see a lot of the policies built, a lot of the limitations built, and this is where a lot of the barriers come in if you are one of those providers who provide a rehabilitation service. So for example, you might have a Medicaid policy that says the service that we are going to cover in the Medicaid program if telehealth is used is mental and behavioral health services when the patient is located in a clinic setting, when it's being provided via live video, and the provider is a psychiatrist. So those are the typical elements, typical limitations that are set up. And when you're talking about rehabilitation services, a lot of times where they ran into problems with that is like either the service wasn't covered underneath a commercial payer's plan or underneath the policies of Medicare or Medicaid, or the type of provider was not allowed to use telehealth to like provide that service. So these were all the changes in which COVID hit, in which Medicare and Medicaid programs actually moved to like make changes and allow telehealth to be used, is like we're opening up and relaxing some of the restrictions that they had that existed pre-COVID. So what do we see? What are the Medicare changes that impacted telerehabilitation? So they did add more services to the eligible list of services that can be provided via telehealth underneath Medicare. So that expanded things. They also expanded the locations, which they allowed the home to be a site where the patient could be when the telehealth service was taking place. And the big thing was they allowed OTs and PTs and other types of providers who typically could not provide services via telehealth and get paid for it underneath Medicare to the eligible list. Now, keep in mind, these are all very temporary changes that are in existence right now. So as soon as the public health emergency is declared over, these relaxations will go away, and things such as the OTs and PTs being eligible providers would no longer be eligible providers. What were some of the permanent changes that have been made so far during COVID-19? There actually have not been many on the federal level. So there's two ways of making permanent changes, through legislation or through administrative actions. Some of the administrative actions that have been taken that do impact OTs and PTs and other rehabilitative healthcare professionals have been done through the physician fee schedule that CMS issues every year. For those who are not familiar with this, they issue it every year around the summer, proposals for what they're going to change to the Medicare program the following year. And then they finalize that later in the year, usually around November or December, and the changes go into effect the first of the following year. So some of the telehealth changes that they made was they essentially added a couple of additional codes in which that will go onto the permanent list that would be eligible to be provided via telehealth. But keep in mind, they did not change the eligible providers list. So while they added these therapy services for PTs and OTs, again, outside of the public health emergency, PTs and OTs would not be able to be eligible providers and bill these codes. The codes and the services would be covered, but the healthcare professionals would not who typically provide these services would not necessarily be eligible. The reason for that is because that limited list of providers is embedded in federal law. So CMS could only go so far. They do have leeway to like add services, but for other changes such as adding like other eligible healthcare professionals to be able to utilize telehealth and get paid for it, they need to wait for Congress to change the law. But the services are added to the permanent list. So what this means is the public health emergency is declared over, these services will still be eligible to be provided via telehealth underneath the Medicare program. I mentioned the communications technology-based services codes. So what they also did was allow other healthcare professionals to utilize these technologies and provide those services. So they did expand that to some of the rehabilitation professionals, such as PTs and OTs and speech language pathologists. So this is like another way of utilizing technology and getting services, though in CMS's eyes, they don't view this as telehealth. So what this means is they have their own rules around them. They don't necessarily have the telehealth restrictions that they typically face, but they do have their other rules that they do have to abide by, that CMS formulates and makes up. And also they have their own sort of separate fee amounts of like what they would pay for reimbursing these types of services. However, it does give like another option for these healthcare professionals to provide services and like have that actually covered by Medicare. What's going on the state level? As I said earlier, there were a lot of changes in response to COVID. We're very similar as far as like the issues that they touched upon both on the federal and the state level. Before COVID-19 hit, the Medicaid programs, every Medicaid program was reimbursing for some type of live video services. Storm forward and remote patient monitoring, the other modalities, was less popular, which is important to note because if the home was going to be a location where you could receive telehealth services, remote patient monitoring usually was where that was happening. So less than like half the states were reimbursing for remote patient monitoring. That most likely meant less than half the states actually allowed the home to be an eligible originating site before the pandemic hit. States also have private payer laws, so this influences what commercial payers need to cover when telehealth is involved, and that ranges from everything from they they can cover, a health plan can cover telehealth services if they wish to, all the way to a law that says health plan you will cover telehealth services the same way you would have in person, and by the way, you will pay the same amount, and then all the other states fall in between. This dictated to the states how much control they had over directing health plans what to do during the pandemic in regards to telehealth. Now, what have states been doing in COVID in relation to telerehabilitation? Like Medicare, a couple of the states have started to add other specialists to their eligible providers list. Pre-COVID-19, a lot of specialists like OTs and PTs, it varied from state to state. Now, keep in mind, you have 51 jurisdictions if you include DC, 51 different Medicaid programs. They all did things differently before COVID-19, and to some extent, they are all still doing things differently, though there's a little bit more similarities to them. One of the things that they did differently is, like Medicare, who they had as their eligible provider to be able to provide services via telehealth and get reimbursed for. And a lot of states did not include PTs and OTs and speech language pathologists and other healthcare professionals, typically in the rehabilitation field, or they were silent on it, so you weren't quite sure if they did include them. But with COVID-19, more states were adding them and being very specific about adding them to their eligible lists. They are also starting to cover more rehabilitation services and also opening up the locations such as the home, allowing that to be an eligible originating site. That third point about allowing the home to be an eligible originating site, that was more sort of a widespread, consistent policy that you saw across the states, which made complete sense as a response to COVID. Now we're in the point where states are looking to see what to make permanent, and they're really debating on what to keep around, which of these temporary changes to keep around. So what are some of the trends we're likely to see? On the federal level, we're starting to see reintroduction of bills that were introduced but didn't really go anywhere in the previous congressional session. They're reintroducing them to make some of these temporary changes permanent. On the state level, the trends are we're seeing more payment parity from the private payers, so having like more laws around what commercial payers are to do. Telephone, which we didn't really touch upon, that was the use of audio-only phone during the pandemic to provide services. We're seeing some of that in Medicaid programs, making that a permanent policy, but in a very narrow scope of things, just really for mental and behavioral health. And then licensing was also a big issue that we didn't really talk about, but again, was one of those policy issues that touch upon the use of telehealth. Became like a big issue during the pandemic because of people getting stuck in different states and trying to reach their healthcare providers, that sort of thing. That's being discussed more heavily or more seriously during these times. And the requirements for regulatory boards to create regulations around telehealth. So these are kind of like the prominent things that we've seen in introduced legislation on the state level. But I do know that both on the federal and state level, policymakers are wrestling with what to keep around. There's concerns about having adequate data on like how well telehealth really provides a service, or how effective it is. Uh, Probably you've seen like questions come up a lot of news articles lately on concerns of perhaps fraud taking place in telehealth, even though the Office of the Inspector General said they haven't really found any telehealth fraud. What they found is more fraud related to telemarketing, not necessarily people making false claims for services taking place via telehealth. So a lot of questions are still out there about what's going to be kept around, but we do know that the public health emergency is likely to last at least until the end of the year. So there's like less fear of having this end abruptly for them. But it has provided, COVID-19 has provided a lot more ability for those rehabilitative services to be provided via telehealth and to be covered, which did not exist before the pandemic. So just a couple of links to the CCHP website and information there that people can access if they like. And I just wanted to thank you.